Good morning, everybody. While folks are still joining us, I'll go ahead and read the wiretap information. And meanwhile, continue to put your name and organization in the chat. That would be great. So I will read wiretap information. In accordance with the Wiretap Act, it is against the law in Pennsylvania to record oral conversations without the permission of folks involved in most circumstances. This session is being recorded for training and/or record-keeping purposes. By participating in this session, you are consenting to the recording, retention, and use of this session. At any time, if you have a question or comment, feel free to place that in the chat and we will respond to you as soon as possible. If you would like to ask your question or comment verbally, please note that by doing so, you are consenting to the recording, retention, and use of your statements recorded as part of the session. Go ahead and exit the call if you don't want to be recorded. You will be able to review the video in its entirety on the DDAP webpage following this event. So we'll go ahead and get started. Alignment of the ASAM criteria 3rd edition is required of treatment providers that receive funding for providing treatment services under agreements with single county authorities and managed care organizations. DDAP strongly suggests reading the ASAM text in its entirety, attending the ASAM training, and reviewing the resources available through DDAP documents and training. These are our learning objectives today. I am joined today by Scott Boyles from Train for Change, and this is the 3rd in a 4-part series. Scott is assisting DDAP to help us navigate some of the nuances of ASAM. Good morning, Scott.
Good morning.
We're going to go ahead and do our first poll. So Amanda, I believe, has just launched that. In addition to putting your name and organization in the chat, we'd like to know who's on the webinar this morning. So if you could please take a second and review the poll and mark the answer that best fits your role, we would greatly appreciate it. And then hit submit. And plenty of folks that have not responded yet. We'll give this a little bit of time. Okay, somebody said they couldn't submit theirs. Sorry about that.
Looks like the poll, or at least it disappeared on my
end.
end.
Did it end? Okay. I'm sorry about that. Not sure what happened, but we'll do our best to capture everybody from the chat. We'll give this another try. We have another poll. We'll leave this up for a little longer. I'm not sure if I gypped the first one up by submitting my role, so I'm not going to touch this one. Amanda, can you launch the second poll? So how comfortable is everyone with supporting individuals with co-occurring mental health needs? 1 would be not comfortable at all, and 10 would be very comfortable supporting individuals diagnosed with a serious mental illness. And then a 5 would be comfortable supporting individuals diagnosed with anxiety and/or depression. And then numbers in between those. So take your time, and you could enter that. We would appreciate it. Some folks are able to submit and some are not, it looks like. So we'll try to get a good understanding of what's going on, but thank you for putting that in the chat. If you can't submit it, we Appreciate it. And maybe it's been disabled. So sorry about that. But we are going to be talking about this topic today. So just having some answers in the chat will be very helpful, I think. Okay, I see. Maybe we disabled the bot. Maybe that's a problem. I'm not sure. But thank you. Thank you for working with us on this. So the Q&A from July's webinar is posted on DDAP's ASAM transition page. I believe this is a live link, so you can use that link to go to our transition page and then go to the July webinar, and you'll see the Q&A posted right beside the video and the slides. So at this time, I'm going to go ahead and hand it over to Scott.
Thank you, Gloria. And thanks for the opportunity to speak a little bit. I just realized this is like Monday. Oops, just lost the PowerPoint. I didn't touch anything, but it just disappeared.
There you go. It's coming back.
Okay. So yeah, 193 people on a Monday. Well, Monday morning for me, mid morning for you. So thanks for coming. We're going to follow up a little bit from last month, and then we're going to shift to really a kind of a pretty broad overview of some co-occurring capability and co-occurring enhanced descriptors. But before we get into that, I'm curious, we last month, regardless of whether or not you're here, but we were talking about ASAM criteria implementation, just like this month, but wanted to focus a little bit on infrastructure. And so how do we know? How in the world do we know if we're using the ASAM criteria? And I'm going to ask you a question, if you don't mind putting it in the chat box. And the question is, let me make a statement first. Without saying training, how do you know, and what infrastructure have you used in your agency to implement the ASAM criteria? So what infrastructure and what tools have you used to implement the ASAM criteria? And I should ask that you can't say training. You can't say training. And so if you wouldn't mind putting what comes to mind in the chat box, like how do you know if you're using the ASAM criteria? How do you know? How do you know if that form you have is actually even related to the ASAM criteria? Audits. How do we know the auditors are auditing the ASAM criteria? Built into the ER, WITS entries, chart reviews. Continuing education is code for training. April, you've outworded me. Corrective action from audits also. Book. Lots of books. Good to say lots of books. Funders. Google and reading. ASAM approved forms. I didn't know there was ASAM approved forms in the EHR. And Gregory, just because I'm curious, when you say ASAM approved forms, are those approved by ASAM? Those are approved by who are those approved by? Just for clarification, if you don't mind. Oh, Arthur, it's not a trick question. Heck, 7:00 a.m. my time. It's too early for trick questions. Could barely come up with a question. Multiple, okay. Forms have been approved by ASAM. Okay, so ASAM, the organization, thanks for the clarification there, Greg. And Arthur, kind of the point is training doesn't equal implementation, and training doesn't equal competency. And so that's what I was just trying to get people away from the training term, because all of these things that you're talking about in some ways might even be more powerful and more useful than training alone. I always like to say you can train someone to surf, but that doesn't give them a surfboard and an ocean. You can train someone in the ASAM criteria, that doesn't give them the infrastructure, the EHR, the forms, the audits, the clinical reviews, the feedback, the corrective action, and a lot of these things, which are super key. And even people are getting into some nitty gritty stuff. I think I saw Betsy connecting dimensions to treatment plans, which might be a file review piece that we would look at for some more specific restructuring treatment plans and clinical documents, as Tina has mentioned. So again, not only building infrastructure to actually use the criteria, but those processes, supervision, et cetera, are certainly key pieces. So I just wanted to see, instead of me just telling you, hey, here's some good ideas, it's like most of the stuff you're already doing. So what kind of measures? And I would just add policies and procedures. Can I open up your policy and procedure man? Can I find your policy and procedure manual? Can I open it up? Can I look at it? And does it tell me how to make level of care decisions? One of the things we continue to see people struggle with, like continue repeatedly struggle, is how do you make level of care decisions? They say, well, we use the ASAM criteria. I'm like, well, what part? What part? Frequently, we're still seeing people use risk ratings instead of the dimensional admission criteria and the related rules. So do we have clear policies and procedures for that? As far as how we make that level of care determination, again, based on the book and some of these other infrastructure aspects that you're talking about. Do we have a policy and procedure on continued stay? Is that reflected either what's in the ASAM criteria book, or really clearly delineating that we base our continued stays based on progress on the treatment plan problem, the related goal, achievement to the specific objectives based on the clinical issues and the dimensions, the justified level of care. And does it really talk about how do we actually do that in the work we do? Same concept as far as transfer and discharge. Could we bust open the policy and procedure manual and see, hey, this is exactly how we make transfer and discharges based on the ASAM criteria. I always like to think that those are the true instructions for the clinician, and or the how to do my work. So key pieces. And then treatment planning, again, frequently we have policies and procedures, right, individualized person-centered treatment plans, but it does give it kind of the specifics as far as how we're connecting that treatment plan to the actual criteria. And as mentioned previously, if we look at a treatment plan, does it reflect the dimensions? Do we have the goals of the treatment plan related to the problem in a specific dimension that was consistent with what we identified at the time of admission to determine level of care? So really kind of nuts and bolts as far as how does this look? How do I do my job? And that not only helps with continuity between clinician and standardizing, so we don't get the three different clinicians might be inadvertently interpreting the criteria in different ways. The policy and procedure manual gives us a clear standard. How many of you just love a good policy and procedure manual? Now that's a trick question. Yeah, we see applause. I don't know who that is. We can't see thumbs up. Probably the QA people, the UR people, the clinical directors and supervisors. Not everyone always loves a good policy and procedure manual, but not losing sight as far as how that really helps us with continuity, sustainability, and helps us with the ongoing traumatic question or the traumatic statement. Well, in my old job, we used to always do it like this. Well, this is not your old job. This is the standard in our program, in our agency. So certainly help with new staff coming in if they've utilized the criteria in different ways. And it gives us a place to build coaching and supervision off of. We don't want to be reliant only on the supervisor to give people direction and coaching, although that's a key piece. But again, that policy and procedure manual can kind of be the written instructional support for offering that coaching, supervision, and feedback. And as noted, file reviews, and whether that's supervisor file reviews or peer file reviews, we always found that was super helpful, as to go read someone else's file. Versus your own, or reviewing your own file. So additional pieces, but just reviewing the file without a reference point to what we're looking for is not always of huge value. So whether it's that policy and procedure manual, or maybe other external audits that you're receiving, as noted previously, some kind of a reference point for how we're doing that, or even in the context of the book. But I always like to tell people, when we think about the ASAM criteria book itself, it's not a regulatory document. And we touched on this, I think, in some of the other sessions, that the book itself is not regulatory. And just for clarification, it doesn't give you the specifics and the specific detail to enforce it. And that's, again, that's why we see states, right? Regulations around the ASAM criteria and get more specific as far as how they're going to measure and interpret application of the criteria, because it needs a little help. It needs a little boost. So the state will do it, and then hopefully, obviously, you're doing that in the context around your coaching and supervision. And then the last piece here, which is sometimes helpful, is staffing, and hopefully not just helpful, but kind of a standard. When we staff the people we serve, if we're doing staff meetings, of course, I know not all providers do staff meetings, but hopefully you are we talking about the dimensional admission criteria when we talk about an initial staffing and how they met the criteria for this particular level of care? If we're struggling with determining level of care, or don't know how to determine actual level of care, is staffing a place where potentially we can also discuss and learn in that environment? And again, the beauty of staffing sometimes is it's something we're doing already, so we're not adding another layer of work or processes to review our work, but we're reviewing our work within the context of doing our work, and there's huge value in that. Treatment planning too. As the treatment plan drives staffing. And we talk about kind of the treatment plan drives care, but does the treatment plan drive our processes? Do we staff the treatment plan, or do we randomly talk about clients? Sometimes in staffing, we talk about clients, we talk about what they're doing, but is that really focused on the treatment plan? And I found at different points in my career, sometimes asking staff members to, I just want, just like in my question prior, just bring the treatment plan to staff, and we just want you to talk about the person you're working with specific to the treatment plan. We want to hear the problem, we want to hear the goal, and we like to hear what objectives they're currently on, and then what they're working on next. So staffing also becomes a continued state of review, as you probably already do, but really focusing on the context of that treatment plan, and how does that relate to the dimension. And this also gives us an opportunity to improve. It's like, wow, every time you read your Dimension 5 treatment plan, it sounds like the same, and I know they're all from different clients. It seems like maybe you're stuck in that particular area. So we can certainly use staffing as a way to coach and provide support for improving the individualization of treatment plans, if that, again, if that's something that's needed. Not saying that's needed by any means for everyone. And then that last aspect of staffing is transfer and discharge. How do we make those decisions? Again, how is that related to the treatment plan? So I think staffing can be a super key piece where we're doing a lot of this work already, and an opportunity to kind of target it around actually that continuity, the ASAM criteria. And we used to use the term golden thread like way back when, a long time ago, and now all of a sudden I'm saying golden thread all the time. But again, staffing and is that golden thread of continuity, and here we're just going to say continuity between connecting the dimensions to the treatment plan and continued state review, transfer, and or discharge summary. And I know for some of you that might be just like treatment 101. And I'm, again, curious, I don't want to talk to you the whole time. I like to hear your perspectives, but just based on some of those additional things, any other things that you have found of value to help kind of connecting these dots from an implementation process, or anything maybe that didn't get posted that you might add when you think about kind of this support, implementation, coaching, and feedback loop for improvement? You can jump in with the chat in the chat box there, I guess, if you have additional thoughts or comments. I don't see anything. Oh, and just this last one here that Christine mentioned, if you are I know some agencies, and it's more designed for residential as the CARF level of care certification. That's another structure. There's workbooks and guidelines for CARF level of care certification or standards for residential settings. And even if you don't have a residential level of care and you're really like into this and wanted another reference point for understanding kind of what the infrastructure looks like for implementing the ASAM criteria, those either the CARF preparation workbook or the standards themselves for level of care can be an additional reference. But that might be for people who are like really excited to understand the infrastructure, because again, it's specific to residential, but some of the pieces in it certainly could transfer conceptually to any level of care. And again, it kind of gives us a picture, and that's historically what we struggled with implementing the ASAM criteria for like 30 plus years now, is there hasn't really been a really consistent, or at times it's been borderline, it has been non-existent as far as the tool. How do we measure implementation of the criteria has been lacking historically. So things like that CARF certification workbook and the criteria around that can be super useful. All right, enough about that. Moving on, co-occurring and complexity capable services. So I apologize for the training journal page. I didn't cut it. So pages 22 and 30, if you happen to like be in your third edition ASAM criteria book. So co-occurring capable, co-occurring enhanced, and complexity capable, three different aspects of programming in the ASAM criteria. And we're going to talk about co-occurring capable and co-occurring enhanced a bit. Before we do that, though, complexity capable. The idea in the third edition for complexity capable was that we work with people who have complex needs. But not all programs are complexity capable. And complexity capable really kind of took into account this idea of federally qualified health centers would be possibly an example, but kind of this under one roof, if you will, service or agency who had multiple different services for people who had really complex needs. So all of the people we serve probably have complex needs, but not all programs technically fell under this complexity capable descriptor. But at the time of writing the criteria, again, back in 2013, they were trying to acknowledge this more sophisticated, comprehensive type of services, which there's definitely plenty of those out there, but they certainly aren't the standard and or the norm. I won't say anything about the fourth edition, but if I was to say something about the fourth edition, I would note that complexity capable is no longer noted in the fourth edition. Not to say that we don't have complex clients or that there aren't certain services that are providing multiple different aspects of care for people with incredibly complex needs. I'd also note, like, it started back in 1994, which would have been, how many years ago was that? 30 years ago. And I remember like seeing tip number 9, and I'm like, oh gosh. I'm not going to read that one because I don't feel qualified. So I just ignored I ignored that one in 1994 where they started talking about people with coexisting mental illness and alcohol and other drug abuse disorders. But point being, for 30 years, this is not a new thing. If there's a tip on it, that would note that it's kind of, I don't know if that's the best measure on the planet, but that would note that this is a significant and priority issue to some degree. So tip number 9, which eventually evolved into Tip 42, which came out in 2005, the first version, which you can probably do the math on that. It's been revised multiple times, and then the most current one came out in 2020. So definitely a lot of information out around co-occurring services, co-occurring capable. And this has been a significant, I don't know if this struggle in our field has been as equal to moving from program-driven care to clinically driven person-centered care, but definitely significant transitions in our field that we've made great progress on over time, and continue to make good progress on, but definitely challenging system change aspects to thinking about becoming co-occurring capable. Not only challenging, but sometimes also incredibly intimidating. Intimidating as far as our work capacity, our knowledge base, our infrastructure, how we receive and bill for services. So lots of significant kind of transition or implementation considerations. So basic, simple definition of co-occurring capable. And there's just some like key words here, thinking about a little bit of this is complex, but it can also be simple. Welcoming patients with empathy and compassion. We're good at welcoming patients with empathy and compassion. This is not a new thing. This is a thing we do already. Integrated services for symptom management as part of routine operations, co-occurring capable. And kind of simple definition of co-occurring capable versus co-occurring enhanced. Co-occurring capable are people who have less severe mental health conditions. Co-occurring enhanced services or more comprehensive, more complex for people who have more serious, possibly more chronic and or long-term mental health needs and potentially cognitive functioning needs. So 12 key elements of co-occurring capable. Again, this has been around for a fairly long time. But again, if you haven't met Dr. Ken Minkoff or heard him speak, he's been on a mission for decades now as far as trying to integrate co-occurring services. And he has this famous, I don't know if it's a famous quote, but certainly is stuck in my mind as co-occurring, is the expectation, not the exception. And it's always been that way. And so I love this 12 key elements because it really kind of simplifies, in some ways I think it makes this whole idea of co-occurring capable a bit less intimidating. And we talked about welcoming. We talked from there is screening. We may not be treating people with co-occurring capable, but at least we're screening. And does anyone know what are any of the screening tools that you might use for co-occurring issues? What kind of screening tools? What kind of mental health screening tools? You might have to type it in the chat box. What are you currently using out there for mental health screening tools? Minus gain, GAD7, PHQ-9, Columbia, suicidal, DSM cross-cutting measure. So all kinds of examples, and some of these things also are examples of measurement-based care, tools that we would use over the course of care, and based on measures that might tell us a bit about progress, lack of progress, or functioning around that particular area. And then something is also as simple as maybe the mini. Screening tools. Initial step, figuring out what our population is and seeing what percentage of our population has needs. So Gregory talks about having a psychologist come in and do an in-depth evaluation of all of our residents. So that would be way beyond a co-occurring capable service. I don't know if it's co-occurring enhanced. That's a great service. And again, that would be beyond the basics of co-occurring capable, but great service. Collaborating with any existing mental health treatment providers. If you don't have the services in-house, most counties, cities, depending on jurisdiction, there's community mental health centers so that we have collaborative relationships with those people who have services, especially if we don't have a lot of services under our roof in our agency. And as noted and as mentioned, is arranging for assessments as needed. And this, again, would not be necessarily a standard across the board, but that could be relative to these initial screening tools and how people score on those initial screening tools. And engaging patients with integrated treatment teams. Again, trying to note that not all agencies and all levels of care may have an integrated treatment team. So are we doing that collaboratively, maybe with an external provider, whether that's someone possibly in private practice or possibly just working with a local community health center and integrating care, especially maybe they're getting care in both entities, but are we integrating that care as effectively as we can in communicating treatment plan strategies, progress, lack of progress, medication, etc. I'm thinking about stage of change, and this is nothing new. We know about stage of change. We've been talking about stage of change forever in dimension 4. As we expand, we can start thinking about stage of change in every dimension, if applicable, but thinking about stage of change around the mental health condition. And as you know, is sometimes people are maybe in a different stage of change for their mental health condition as they are for their substance use, or as they are for maybe even different substances. So understanding stage of change, and same model and process that we think about the people we serve with substance use disorders. Are we matching interventions appropriately? And just because I love the stage of change plug, I always feel like I need to do, is stage of change does not drive level of care decision. Stage of change really drives our approach and our clinical interventions on the treatment plan and our considerations of how we might engage with this person and what might be the best intervention or the best activities in relation to the treatment plan and or the related objectives based on that person's stage of change. And noting its stage of change is not person specific, it's issue specific. So as noted, might be different mental health or across different substances. Helping people learn about their mental health concerns and offering interventions. And just again, I'll ask you, I guess this is just how I train. I'm not used to talking the whole time. I talk the whole time when you don't want to hear me, and when you don't want to participate, I probably ask for your participation. I've never got the timing perfectly. But what are some basic things, without even thinking about mental health, what are some basic interventions that we use all the time to help people manage emotion? What are some basic interventions? I like that, Marty. Keep it simple. Just by listening can be quite powerful. What are some other things? Whether it's clinical skills, or maybe there's certain activities, or maybe you have certain curricula that you might use. Validation, grounding, motivational interviewing. Psychoed, excellent, psychoed. The triple R, thank you, April. Retreat, rethink, react. Mindfulness, bravo. DBT, CBT. So good examples. And when we think about the third edition of the ASAM criteria, dimension three, emotional, behavioral, cognitive conditions, which so this is, you know, in some ways the emotional aspect, and we're not just talking about all emotions, but a key piece of working with people with mental health conditions is emotions. Does anyone do anything around trauma? Yeah, anything around trauma? Primary and secondary emotions. Is that like the anger umbrella and then the emotions underneath it? What do we do on trauma? Trim. Good participation for a Monday. Trauma informed, yeah. So that uh, EMDR, TFT, yes. So trauma could be obviously a piece of this, and this is a thing that most providers are pretty attuned to. So it doesn't necessarily have to be, hey, we need a psychologist on staff or a psychiatrist on staff, or we need half a dozen LCSWs. Maybe one or two LCSWs, maybe just one, or maybe contracted with one. Again, depending on our agency, depending on the population we're working with, depending on our resources, our location. Self-regulate, yeah. So we could now you're on fire. So sanctuary training for our staff. So more trauma, seeking safety. So we're already doing a ton of stuff in this area. Um, Helping patients with skills to work effectively with prescribers. And I love this. And I'm just, you know, we had Dr. Ken Minkoff on a webinar a few months ago, and I just loved how he described this. It's like if you have a patient who has like a medicine, like any kind of medicine that they're taking, and they don't like it, or they aren't able to access it, or it's causing side effects. I'm talking like an antibiotic. I'm talking like a medication for anything, or their insulin, but kind of any medication, that we're appropriately within our scope of practice to listen to them talk about their medication. We're appropriately within our scope of practice to give them suggestions on how they might work with their prescriber or talk to their prescriber about that medication. We might even give them tools from kind of an educational aspect about how to manage medications as a whole. So those would be normal and appropriate things we would talk about. If someone said, hey, I'm taking this medication, it's making me sick to my stomach, or it's keeping me up at night, we would have that conversation with that person. So we can have that conversation with that person around their mental health medications, back to engaging, back to listening, back to people wanting being heard. And that can be very appropriate. And then hopefully we would provide connections and or supports to help them have those discussions with their prescribers. So another kind of a thing we probably do anyway, and possibly a piece that could be also facilitated by case managers. But key pieces. Culture supportive of co-occurring recovery. So this is part of what we do. This isn't a nuance. This is like, wow, we got a person with a co-occurring condition or a mental health issue. Like that shouldn't be a surprise, as noted. That's part of what we do. And the culture within the context of our agency is both substance use disorders and or mental health conditions. Kind of the basic obvious is that transition planning definitely incorporates needs around the mental health condition, and as frequently that's going to obviously, I guess everything obviously we're talking about is most often going to come up in dimension 3. Also note, just why I'm thinking about it, sometimes in dimension 5 in the third edition it says continued problem potential. In dimension 5 in the third edition, where it says continued problem potential, it's saying that because it's also asking us to think about that emotional behavioral issue or that mental health issue in dimension 5 under that term because people don't necessarily relapse from a bipolar condition or depression or anxiety. We're thinking about what's the continued problem potential based on the historical patterns of behavior, based on the current pattern of behavior, assessing continued problem potential in dimension 5 if there is a co-occurring condition. And when we talk about co-occurring conditions too, this may not have a formal diagnosis. They use the term subdiagnostic in some of the describers in the 3rd edition. It's subdiagnostic, so it may be significant behavioral issues where there's not a formal diagnosis. And just why I'm on it, when we're thinking about, so if there is a diagnosis alone doesn't tell us about the severity of the condition. So as we're thinking about these conditions and the needs in care and as part of the transition process, we're thinking about, how is this impacting the person's life? How is this impacting their ability to function? As you know, I bet some of you have mental health conditions. Lots of us have mental health conditions, and we function really well. And lots of the people we serve have diagnosed mental health conditions, and that diagnosis alone does not tell us much about their functionality. So we're really thinking about function limitations around this condition, not just diagnosis alone. Key piece when we're thinking about assessment and understanding clinical needs. Yes. And Betsy's just talking about, yes, safe place, which also thinking about trauma. So co-occurring enhance, more serious mental health or cognitive conditions, more serious disabilities, more acute. And it says, just to note here, successfully participate in addiction and mental health services. So there may be some people who have such acute mental health needs, they really need to be in more of a mental health service system that has greater capacity. So when we're thinking co-occurring enhanced, these are for people who are significantly more compromised, but still can benefit from and or need to be in this integrated model of care with substance use disorder and their mental health condition. At times, some people may need, because of the severity of their mental health condition, may need an initial target and focus just very specific to that mental health condition. So what's different about co-occurring enhanced services? So we're working with people who are more compromised, and in that compromise, serious long-term mental illness, there might be serious cognitive conditions, either in relation to the mental illness or potentially also long-term heavy substance use or additional severe cognitive conditions. But we're going to have higher staff to client ratios as far as helping manage and support behavioral issues. Potentially smaller group size with this population, and the design and who's facilitating those groups are most likely going to be people with mental health credentials and expertise in mental health. Accommodate patients with significant behavioral problems. Again, so staff are trained and the setting is designed to work with people where we know that, again, behavioral problems may be more of a expected part of the care we provide and the care we manage, not just a surprise. So behavioral problems would not preclude the person from services. We talked about more severe co-occurring conditions. What does that look like? Severe mood disorders. There's a whole list here. I won't read them all to you, but just also noting at the bottom here, severe trauma-related or anxiety disorders. So again, kind of where trauma, again, is noted here within the context of co-occurring enhanced, or also relative to co-occurring capable, but more severe disorders. We don't, as the field has evolved, I think we're seeing more and more co-occurring enhanced services. I think, I'm hesitant at saying this, but possibly that maybe the co-occurring enhanced providers are mental health organizations who have adopted substance use disorder treatment, and they had that pre-existing infrastructure, expertise, and staffing pattern to work with people with more severe conditions. I don't know that we're seeing as many substance use disorder providers who are evolving and becoming more co-occurring enhanced. Not to say that that can't happen, or not to say that that doesn't happen, but I think more of the co-occurring enhanced service providers are probably where existing mental health agencies who again adopted substance use disorder services, or maybe historically had substance use disorder services. That's kind of I said it was a brief overview, and it really was a brief overview. I wish I had a whole bunch of more slides to go over with you, but I don't. So questions either on this, and or I would just throw it out there too, if you have questions that maybe didn't get answered in previous trainings, or anything related to the criteria, I say feel free to jump in. Sarah, kind of off track. That's good. You're on track though with your off track, so I like it. Let's see. We have recently had a client decline screenings toxicology testing in our outpatient services. What is ASAM's take on mandating these for outpatient services? ASAM has a document, and I don't know the official title of it, but it's on basically drug screening. So you might reference that, and you can find that on the ASAM website. I don't think that they have a pretty, I feel like almost 100% safe to say that they don't mandate drug screening for anyone. I don't think there's any service that's mandated for anyone in the context of the ASAM criteria. I think they would suggest that drug screening is part of a best practice, and may be applicable and appropriate for the population. We know it's a key aspect of possibly providing methadone services. It's a quality care, and it's a safety issue. So my question back to you would be, why are we doing drug screening in the first place with this person? What's our clinical rationale? How, in drug screening, mind you, also is a clinical intervention. So drug screening would be part of a treatment plan. And just for the sake of discussion, or to thinking about how drug screening might fit, first we have a problem on the treatment plan, then we have a goal, right? Treatment planning 101, I know. Then we have objectives. And the clinical interventions are specific to helping the person served accomplish the objectives. Clinical interventions are services delivered by the provider. So if I saw drug screening under clinical intervention on a treatment plan, I would want to see, how is that connected to the objective? How is that connected to the objective? What objective is it? And then obviously, how is that objective supporting accomplishment of the goal? And if the treatment plan is a collaborative relationship and a partnership where we develop the plan of care with the person served, how did urine drug screen get on that treatment plan if they're opposed to it? And or, coming back to your question too, if they are opposed to it, that to me sounds like it's a mandated and required thing. Why is it mandated and required? Who's mandating and requiring it? Is this part of a court order, a court requirement, where you're just acting on expectations from the court, which would make it more understandable? But then what happened would be is, well, what happens if you don't follow your court requirement? That would be between the client and the court, not between us and the client, but we would definitely have that discussion. So those are some things that I'm thinking about. Kyle, I don't know if that, oh, thank you, Madison. You are so on top of it. Gloria, let's make sure Madison gets.
That's Amanda.
Oh, I'm sorry.
That's okay.
Let's
And
make
Rebecca,
sure.
they both simultaneously put that in the chat. So thank you both.
Let's make, hi Rebecca. Let's make sure they get extra CEUs. If this wasn't state-sponsored training, I'd be sending you money through Venmo for doing that, but we can't do it with the state-sponsored trainings. Okay, so let me, and Brittany, hopefully that what I talked about is 3.5. That'll address 3.5 also. And in 3.5 too, maybe the other aspect of this might, again, which would be another piece we would think about with drug testing. There's a safety issue. There's a safety for staff. There's a safety for the other patients. So that certainly could be another component that we would be considering around drug testing. I'm not saying we do drug testing for everyone, but that might be another consideration in that residential setting where we're supposed to be providing a safe, in theory, a safe drug-free environment. So maybe drug testing could be an aspect of that also. Do you think there's a reason that substance use providers aren't doing COE as much as mental health providers? My subjective perspective on that, Laura, is substance use treatment providers are highly trained in dealing with substance use disorders, and they haven't had the infrastructure, training, credentialing requirements, education, like mental health providers. And historically, the mental health system, there was a mental health system and there's a substance use disorder treatment system, or an addiction treatment system, or a chemical dependency treatment system, and a mental health system, and they were separate. And so I think the mental health system evolved and the substance abuse disorder treatment system evolved in their own kind of trajectories. And then we've worked over years to try and bring them closer and closer together. But I think the roots and the infrastructure, clearly have been there for mental health. Just like we don't see a lot of, it's amazing in the last 5 years, last 10 years, how many mental health clinicians are showing up in training that we're doing around the ASAM criteria, saying, I've never worked with people with addictions. And it's like, awesome, we're so glad you're here. Thanks for showing up. But they haven't had the infrastructure, training, everything else in place historically. And this isn't true across the board, but historically to address substance use disorders. And mental health referred people with substance use disorders to the substance use treatment system, and vice versa with people with mental health conditions who showed up in substance use disorder care. So we've historically had that kind of siloed service system. What else we got?
Scott, there's one question. Do we see increase in mental health symptoms after rehab? I think maybe you missed that one. I don't.
Do we see increase? We can, and again, my expertise is not totally in the treatment of mental health disorders, but people, or we might see the increase in symptoms when people enter treatment, when they've discontinued their substance use. We might see additional symptoms. We might see increase in more intense symptoms. So that could be a yes, but it's not. I don't think there's a standard expectation there, but definitely something would be screening for when we're looking at the person's history of substance use in conjunction with their mental health condition. What's and how have periods of discontinued use or periods of abstinence, what has their response been, either behaviorally or as far as some of those identified symptoms? Is there a new ASAM coming out soon? It's already out. It came out like in, I think you could start purchasing it like in October. But yeah, the 4th edition of the ASAM criteria is out. Treatment court requires it. Sometimes do it along with the court in our county. That might be the urine drug screens.
And there's also a couple more on the urine drug screen. If a resident refuses a UDS, shouldn't they be discharged? And then, I don't know if you want to address that.
I don't know why we would discharge them if there's more backstory to that. Like, I guess there's so many more questions. Like, what's wrong with refusing a urine drug screen? Why do I have to pee in a cup? Like, what does that have to do with anything? Help me understand as a patient. And why would you kick me out if I don't want to do it? It's like, why? Like, what is it? So again, I'm thinking, is this person court required? Are we suspecting they're using? Are we concerned about their safety? And then I also be curious to know, why don't they want to do it? And why do they have to?
And then Scott, can you take a look at Kate? I think we might have to go into, I don't know if we're going to have time to address all of the questions, and we may have to sort of continue this, but we have gone into pretty much detail in the last couple months over urine drug screens being used as an intervention as part of the treatment plan, but it related to individual necessity. So I'm not sure if you have time to address that now, or if we should expand on it next month, but there seems to be a lot of questions around this.
Yeah. And this has come up. Kate, were you and I who talked about another trend? But and Gloria, maybe we talked about this a little bit about the urine drug screens coming up in the audits. Kate's question,
Right, exactly.
and maybe that's what you're referencing.
And maybe it's something that we need to take back and have more discussion with our weekly team meetings to sort of reword the tool. Perhaps I don't know that that's what is necessary, but we'll look into this more if there's still a lot of questions out there about what the expectation is.
Yeah. And I think there's so many different components of what, again, the clinical intervention that in theory would be somewhat related to that treatment plan, and or there might be additional safety issues. Also, if we're prescribing medication for people where urine drug screening could be key. But I love this last comment, and I'm back, is it Diarlo K? I don't know if that's your first name, last name. I'm talking about motivational interviewing. Again, around the urine drug screen, and then also thinking about, how does that impact our engagement? It's like, I'm going to urine drug screen you. Well, when we think about this is again motivational interviewing. This is a collaborative partnership with shared decision making. Where I'm not judging you, where we're establishing, again, this engaging relationship. And as we think about urine drug screens under that umbrella, or if we use that umbrella to start thinking about when we're doing urine drug screens, what the point is, what the purpose is, how does that impact the relationship? What does that tell us about the relationship? And I don't know I'll just give you one bias piece here. I grew up working in a field where we like to catch people with what they're doing wrong. We like to catch them lying. We like to catch them as inconsistent reporters. We like to catch them as minimizing. We like to catch them with urine drug screens. I can even remember as we do a urine drug screen one day, and then with adolescents, we do a urine drug screen 2 days later. And our policy / thought was, we're going to catch them on the celebrating of the passing of the first urine drug screen. So we'll do another one 2 days later to catch them, because we knew they would use after they passed the first one. So what did we get from that? What was the outcome? Well, we proved we were smarter than them. We caught them doing drugs. It's like, woohoo. So, but what was the actual, did that help them? Was that of value? Was that building our trust and rapport with the person served, or was that putting us in more of a chemical dependency counselor cop role? And at times we turned into cops, and then we act surprised when people were dishonest and resistant. Well, we were acting like cops trying to catch them with stuff, and they were just responding to our behavior. So stuff to ponder. And again, there's lots of different, we could go on for days about this. Good questions, but I think the key piece also that keeps coming up in a theme here is maybe clarification on some of the alignment piece, which I know it's been clarified, but continued clarification on the alignment piece and what are people expecting for urine drug screens from that angle.
And we also have a couple outstanding questions. Jess, I see your question as well. I think what we'll do is we'll address this next month about individuals being administratively discharged for certain behavioral concerns. I'll make sure that you have that detail, Scott, so that you can work on maybe addressing this next month, if that's okay, along with other planned topic for next month. Scott, do you have anything you want to say before we close?
No, and I did see that one on the discharge for behavioral concerns, which we can again cursory touch on it next month. Some of these I think require more specifics and really it's borderline clinical consultation stuff that I think would be more valuable in a different format. But again, thanks for your time. Thanks for all the questions. That's pretty cool.
Yeah.
I really appreciate, and if we didn't get to every single one, I'm sorry for that, but thanks so much for your interaction. I think that makes this so much more valuable.
Yes, thank you, Scott, so much. We appreciate your guidance and appreciate all the feedback from everybody and the questions and the engagement. We'll see everybody next month. That's September 9th. We'll skip the first Monday since it's Labor Day holiday, and we'll see you on the 9th at 10 o'clock. Have a great rest of your day, your Monday, and a great August, everybody. Take care. That's the end of the presentation.
Thank you. And Gloria, just